The Knowledgeable Provider podcast is educational, entertaining, and not the same as medical training. The information presented here should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, go see your own knowledgeable medical provider. Opinions expressed on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies, and I have no other relevant financial disclosures. It's all fun and games until someone gets sued, am I right? Okay, on with the show. Hello, welcome back to Knowledgeable Provider. I'm your host, Jody Marks. We made it to K in our Alphabet Soup series, so today I'm going to talk about kidney stones. I guess that could be seen as cheating since the real medical term is nephrolithiasis, but that's the first K thing that popped into my mind, so we're going with it. First to the news. I think the big medical headline in the past couple of weeks has been the CDC changing its website to basically say that we're not sure whether or not there's a connection between vaccines and autism. Of course, this is a long debunked claim that our Secretary of Health and Human Services has long disagreed with. The explanation on the CDC website, which I will put a link to in the show notes, says that, quote, "The claim, vaccines do not cause autism, is not an evidence-based claim because studies have not ruled out the possibility that infant vaccines cause autism," unquote. It goes on to say that health authorities have ignored studies that support a link and that the CDC putting out information saying that vaccines do not cause autism is just, I'm paraphrasing, it's just a ploy to get people to get vaccines. NPR had a story about this. They interviewed Dr. Susan J. Cressley, who's the president of the American Academy of Pediatrics. Dr. Cressley says, quote, "Since 1998, independent researchers across 7 countries have conducted more than 40 high-quality studies involving over 5.6 million people. The conclusion is clear. There is no link between vaccines and autism." This is still her. "Anyone repeating this harmful myth is misinformed or intentionally trying to mislead parents. We call on the CDC to stop wasting government resources to amplify false claims that sow doubt in one of the best tools we have to keep children healthy and thriving, routine immunizations," unquote. I think I'm with Dr. Cressley on this. I've already said in an earlier episode that I'm going to start paying more attention to the professional medical societies and less attention to guidance from the federal authorities while these people are in charge, and this is a good example of why. There's another quote in the NPR article from Dr. Paul Offit, who is director of the Vaccine Education Center at CHOP, Children's Hospital of Philadelphia. Quote, "These are the usual anti-vaccine tropes, misrepresentation of studies, false equivalents. They might as well say chicken nuggets might cause autism because you can't prove that either," unquote. I mean, there are a lot of preservatives in those chicken nuggets. I'm kidding. I'll put a link to the NPR article in the show notes as well, and you can decide for yourself. I think this is a pretty disturbing example of bad information coming out of the CDC because of who's in charge of it, not because of science. All right, kidney stones. Very common thing, obviously. I've never had the pleasure of enduring one myself. Hope I don't ever. But of course, we take care of a lot of patients who deal with this. My impression is that it is extremely painful. These are the people who are sort of bouncing around the room because they can't sit still because they're in so much pain. People with obstructing stones. I'll talk about diagnosis and treatment of an acute episode of painful obstructing kidney stones and how we deal with that. But really what I'm more interested in at this point is how to figure out how to prevent people from having those stones in the first place. So classic presentation of an obstructing stone. And let me go ahead and backtrack and say obstructing means obstructing the ureter. The size of the stone plays a big part in how much of a problem it's going to end up being clinically. If it's a stone less than 5 millimeters in diameter, it's probably going to be able to traverse the ureter and pass without causing any problems. If it's more than 10 millimeters in diameter, it's probably too big to get into the ureter, so it's just going to sit in the kidney. It's the ones in the middle that are going to cause the problems. 5 to 10 millimeter stones, they're big enough to get into the ureter and start down the trail, but they may not be small enough to pass completely through. So mostly I think when we hear the phrase, "Oh, I have a kidney stone," what most people are talking about and what most people think of as an obstructing stone. So that's a stone that has left the kidney, is en route to the bladder, and is stuck in the ureter. That is what causes the pain. Obviously, it can have urine back up into the kidney and cause hydronephrosis. It can be a nidus for infection, so you can get a urinary tract infection out of this or a kidney infection. So it can be a bad deal. Classic presentation is flank pain. along with blood in the urine that may be visible, or you may only see that on your urinalysis. There can be less obvious symptoms. People can present with just vague abdominal pain, nausea, urinary frequency and urgency, difficulty urinating, or pain in the genitalia. It's not always clear cut. Another way that we often realize somebody has kidney stones is they go get an imaging study for something else, and the radiologist will see stones sitting in the kidneys that the patient may or may not have known they had. So what do we do if somebody comes in and we suspect they have a kidney stone, meaning an obstructing stone, right? They're complaining of flank pain, nausea, whatever. To me, that depends on whether this is somebody who has had kidney stones before or not. People who have had a lot of kidney stones will come in and say, hey, I think I have a kidney stone. Or they won't come in at all. They'll call and say, hey, I think I have a kidney stone. Can you send me something to help? I think it's pretty reasonable if somebody who's had a bunch of kidney stones before comes in and says, hey, I have a kidney stone, to just trust them and treat it as such without necessarily doing anything else as far as testing, unless you have some reason to suspect a different cause, or unless this seems different than their typical stone experiences. Of course, it's a little more challenging if someone's never had a kidney stone and they come in with these kind of symptoms. Ultimately, you're going to want to send them for imaging to find out whether or not they have a stone. Preferred modality is going to be CT without contrast. Everywhere I've ever been, you can order what's called a CT stone search. There's also a thing called a CT urogram, which involves using contrast to get a better view of the urinary tract. Most of the time, a non-contrast CT is fine for this. Obviously, in pregnant patients, you're going to want to use ultrasound instead of CT. In general, ultrasound not as reliable for detecting stones, so CT is the preferred modality. Also, in these patients, not a bad idea to get a metabolic panel and a urinalysis. That will tell you something about whether their kidneys are working or not, and tell you something about what's going on in their actual urine. Of course, it would not be a surprise to see hematuria on the urinalysis. If there's any signs of infection, we want to treat that. I find that the urinalysis is a pretty decent way to help differentiate, at least initially, between people who have a urinary tract infection that has symptoms similar to a kidney stone from people who have a stone. If you just see blood and nothing else, to me, that leans more toward it being a stone, versus if you have particularly nitrites, that's going to push you more toward infection. You can have both problems, right? But that's a good initial way to push yourself in one direction or the other. So how are we going to treat these people? Pain management is going to be your main focus, typically NSAIDs and or opiates. Obviously, we prefer NSAIDs if you can get away with that, but a lot of people are going to be really in severe pain. These are the people that you are going to feel compelled to give opiates to. The preferred NSAID for initial pain management is ketorolac, brand name Toradol. But, NSAIDs kind of interchangeable, so I don't know that it really matters a whole lot. One advantage that NSAIDs do have is that they help decrease the smooth muscle tone in the ureter. So you're not only masking the pain, but you're doing something to treat the underlying cause. Along those lines, you can also give an alpha blocker, usually tamsulosin, brand name Flomax. Same idea. It helps relax the smooth muscle in the urinary tract and facilitates passage of the stone. If you can't do tamsulosin for some reason, other alpha blockers will suffice. So terazosin, doxazosin, alfuzosin, silodosin. Nifedipine may actually have some benefit here. Calcium channel blocker doesn't seem to work as well as the alpha blockers, but that is something you could keep in your back pocket. It makes sense that PDE5 inhibitors might be helpful. They cite a study in the up-to-date article about this that showed silodosin was actually the most effective thing that they were studying for stone expulsion, but tamsulosin and tadalafil both had comparable times to stone expulsion. And of course, you could use those two things in combination, right? We have patients on alpha blockers and PDE5 inhibitors all the time. As long as the patient is okay, as long as they're not super sick or in overwhelmingly severe intractable pain, nausea, that sort of thing, it's usually appropriate to let them hang out outside the hospital and wait for the stone to pass, even for up to a month. The recommendation is to get them on to urology if they go 4 weeks without passing the stone. I don't know many people who would put up with kidney stone pain for a month, just based on what I have seen. If they do have any sort of red flags, especially acute kidney injury, they're not making urine at all, if you can't get their pain under control, or if it looks like they have an infection on top of the stone, those would be reasons to get them on to a urologist and not try to do more conservative therapy. I don't love the idea of sending people to the ER for kidney stones. I would do that if they were just miserable and I could not get their pain under control. Or I think the anuria thing, if they came in and told me they hadn't peed in 3 days, that would be a reason for me to send somebody to the emergency room, I would say. Or if they look septic, right? If they're really febrile and sick looking, I might advise an ER trip in that situation. And then, of course, once they get to the urologist, then they discuss whether or not we do something to actively remove the stone. That discussion's kind of out of my wheelhouse, but your options are lithotripsy, where they use sound waves to break up the stone. That can be done non-invasively, or they can go directly to the stone wherever it is and blast it like that by means of a ureteroscopy. They can go in like that and physically remove the stone, grab the stone, and of course they can do an open surgical procedure to get to it as well. All that is for urologists to figure out, but you will definitely meet people who have had procedures to remove stones. One pertinent thing to know about those kind of procedures is many times they will leave a stent in the ureter. So they'll go in and break up the stone, and then they stent the ureter to keep it open to help increase the chances that those stone fragments are going to come out of there. In those cases, the patient will have a string that is visible on the outside. So they'll leave a tail. It sort of looks like suture that will be coming out of the urethra. And at some point that stent has to be removed. People do not like this. Apparently these stents are pretty uncomfortable. People also do not like when they have to be removed. Urologists will tell people to just remove these things at home. Most people I've talked to aren't really so comfortable with that. I think most people prefer to go back to the urologist's office and have them remove it. I'll tell you, when I worked in PACU, people who woke up with a ureteral stent after a procedure to remove a kidney stone, if they had ever had one before, without fail, they were mad when they woke up with that stent. It's apparently not fun at all. And I don't think there's anything super technical about removing it. I think they really just pull it out. I can understand why somebody would not really want to do that at home. That's about all there is to say about management of an acute episode of an obstructing kidney stone. I want to move on now and talk about more of the thought on how to prevent people from getting stones in the first place, which I think is the more interesting topic, really. My impression of this might be wrong. I'm just saying this based on anecdotal experience. But I've run into a lot of patients who are just sort of resigned to having kidney stones. They'll come in and say, I've had 50 stones. I got another stone, no big deal. I don't know what urologists do in these situations, but it seems like, from my perspective, that a lot of times we collectively are dropping the ball on helping patients do more to prevent themselves from having kidney stones. My guess is that for people who've had a ton of stones, they have been through the process of figuring out what kind of stone it was at some point in the past, and they just kind of didn't pay attention to the advice, or they tried it for a while and it didn't make any difference. I don't know what that is. But I think there are a lot of people running around out there who just think it's their lot in life to have kidney stones all the time, and maybe don't even realize that you can do something to try to prevent those stones from forming. I have had some success with this in the outpatient setting, so I try not to let these things fall through the cracks and actually at least check into whether or not somebody has an idea of why they form stones and if they know something that they might be able to do to help prevent them. So in order to give specific advice about what to do to prevent a stone, you have to know what the stone is made of. Sometimes they can tell based on imaging what the stone is made of. I don't know that I personally have ever seen that on an imaging report locally, but evidently there are differences in how the different types of stones present on imaging that can give you a guess about what kind they are specifically. Most kidney stones are going to be made of calcium oxalate, 70 to 80%. Other common things are calcium phosphate, uric acid, and struvite, also known as magnesium ammonium phosphate. These don't have to be exclusive. Sometimes stones can contain more than one thing. Less common things that stones can be made of are cysteine, DHA, which is 2,8-dihydroxyadenine, triamterene, as in the medication, and acyclovir, as in the medication. So the ideal way to figure out what a stone is made of is to actually catch the stone and have it analyzed. The way you do that is you give the patient a strainer through which to urinate and hope that you actually catch a stone that you can send to the lab and have analyzed. Sometimes you can get an idea of what kind of crystals are in the urine just from a urinalysis. A lot of times when they do that, they can actually see the different kinds of crystals when they do the microscopy. Probably a better way to figure this out is to do a 24-hour urine collection. Of course, while that's going on, you want the patient to just do whatever they normally do, right? Usual diet, fluid intake, physical activity, because we want to know what's in their urine in the course of normal life. They recommend doing at least 2 different 24-hour urine collections, which is a lot to ask someone to do. But just to confirm that what you're seeing is legitimate, it's a good idea to do it twice at least. So specifically what you want to know from a 24-hour urine collection is how much of common kidney stone forming things are they excreting. So you want to know about calcium, uric acid, citrate, and oxalate. You're also looking at the urine creatinine, which gives you an idea of how complete of a 24-hour urine you actually got, as well as the pH, sodium, potassium, and magnesium, since all those things are going to contribute to conditions which may be more or less favorable for formation of kidney stones. So then once you have a better idea of what kind of stones the patient is making, then you can give more specific advice about what to do to prevent them. There are some good pieces of advice you can tell everybody with kidney stones, whether you know the composition of them or not. Obviously, the more concentrated the urine is, the more likely stones are going to be to form. So encouraging people to increase their intake of fluids is helpful. Ideally, we want to be making about 2 liters of urine per day. If you have a 24-hour urine collection available, you're going to actually know how much a given patient is producing in a day. So you could make a recommendation about specifically how much more fluid they should be drinking. Some other lifestyle things that can be helpful, it's exactly what you would think. It's eat more fruits and vegetables, limit your sodium, and lose weight. The same things that we recommend for pretty much everybody for pretty much everything. For people with calcium oxalate stones, the most common type, you want to tell them specifically to reduce their intake of non-dairy animal proteins in their diet, have them limit their intake of oxalate, kind of makes sense. Things that have very high amounts of oxalate in them include spinach, rhubarb, and potatoes, as well as some nuts, including almonds, peanuts, and cashews. Seems like there's not a great deal of evidence that doing this has a huge effect on stone formation. Another thing that increases the amount of oxalate in the urine is taking a lot of vitamin C. So in some people, if you take high doses of supplemental vitamin C, that can make you excrete more oxalate. So you want to tell these people to stay away from a ton of that. You want them also to stay away from sucrose and fructose as much as they can. You might think that you would want to tell them to limit calcium intake, since that is the other component, but that is not a good idea unless they're just really taking a ton of it. There's a paradoxical thing where if you take in less calcium, that's going to cause you to absorb more oxalate from your diet, and so it's going to potentially make the problem worse. So we're not recommending low calcium diets. If you want to add medication, you can use thiazide diuretics, which reduce the amount of calcium excreted in the urine. It's helpful to get some citrate into the urine. This actually helps inhibit stone formation, so you can have them take potassium citrate or potassium bicarbonate if you find on your 24-hour urine collection that the urine citrate is low. If the person also has high uric acid levels in their urine, decreasing that can also help reduce the risk for forming the calcium oxalate stones, so you can put those people on allopurinol. Prevention of calcium phosphate stones is pretty similar. You might think that reducing dietary phosphate would be helpful in these people, but we don't have any studies that have looked at that, so not something we would advise. With uric acid stones, obviously you want to try to lower the uric acid level, so allopurinol, or there are other medications available for that. Same as what you would do for somebody with gout. The urine itself really has to be acidic for uric acid stones to form, so you want to think about trying to alkalinize the urine in these people, so you can do that with potassium citrate or potassium bicarbonate. Struvite stones are a little bit of a different animal. These are actually called infection stones. They develop in the setting of urinary tract infections with organisms that split urea. So in order to get rid of these things, you have to treat the underlying infection and you have to get all of the stones out of there. They don't necessarily always go in and get kidney stones. If a stone's just hanging out in the kidney, not causing any problem, there may not be a reason to go in and get it. You may just watch it or change the plan if symptoms develop of obstruction or some other problem. But in the case of a struvite stone, you have to get them out in order to really cure the patient. Of course, they're going to be treated with antibiotics. And sometimes you can give these patients a urease inhibitor. The example is acetohydroxymic acid, or AHA. If they make cysteine stones, again, you want to alkalinize the urine with potassium citrate or potassium bicarbonate. And then you can add a thiol-containing drug, which would be something like tiopronin or D-penicillamine, that help to reduce precipitation of cysteine. So those are some specific things you can actually do when you know what kind of stones a patient makes to help them not make more stones. I hope that urologists do a lot of this. A lot of this, I think, would be a little out of my comfort zone in primary care, but I'm certainly comfortable trying the potassium citrate, potassium bicarbonate in situations where you want the urine alkalinized. I'm certainly comfortable trying thiazide diuretics. More times than not, I think you're going to find yourself in a position where you don't know the composition of the stones and you're not going to be in a position to do the real testing that should probably be done. I have recommended in those cases trying a thiazide diuretic and or trying to increase the amount of citrate in the urine, just because more than likely they're calcium oxalate stones, and more than likely those things are going to help. So I would say this is Jody's advice. This is not up-to-date advice. I would say if you are in a situation where you're just seeing somebody that has kidney stones and you want to just tell them something quick or come up with something quick you could do to help prevent them, more than likely it's calcium oxalate. So you could add a thiazide diuretic and then have them start potassium citrate as well. And then follow the advice about dietary modification and increasing fluid intake. You're going to be right most of the time about that. But of course, ideally, you want to know with more precision what you're dealing with so you can make sure you're giving the right advice. So there you go. There's kidney stones. If there's something I got wrong or missed or something you want to add, please feel free to email. Thank you so much for listening. Special thanks to our Patreon supporters. Everyone drink lots of fluids this week. Hopefully no kidney stones. All right, have a great week, and I'll talk to you later. All right, that does it for this episode of Knowledgeable Provider. Very special thank you to our Patreon supporters. If you would like to help support the show for just $5 a month, please head over to patreon.com/knowledgeableprovider. If you're looking for more content, check out our YouTube channel and our Facebook page. Remember, all of those ratings, reviews, likes, follows, subscriptions, etc. really do help the show, so take a second and do those things to help me out. If you have a request for an episode topic or if you'd like to be a guest on the show, I'd love to hear from you. Email me anytime at thekppod@gmail.com. That's thekppod@gmail.com. Thanks so much for listening, and as always, stay safe, take care of yourself, and take care of your patients in that order.